Not only is our population ageing in an environment where medicine and healthcare more broadly is affording at least our generation longer, healthier, happier lives, there's also the burning question of cost. On top of this, there's the issue of whether our children and our grandchildren will benefit from the system as it currently stands, or whether what we hand them means that they draw the short straw. But the mantra across all facets of life these days seems to be doing it better, doing it smarter, and of course, doing it cheaper. So having heard last year about what various arms of the healthcare industry need and want, today is really about continuing that discussion. And it's also about asking what you can do and what you are doing to actually make it happen. To do this, we have with us a fantastic panel of amazing people who are intimately involved and dedicated to these issues. We have with us Michael Ackland, who has been CEO, Michael, you can put your hand up, just tell us where you are, who's been CEO of GE Healthcare for Australia and New Zealand since 2012. His role has been to define and advance GE's strategy and growth. Prior to joining GE, he was a consultant for the Boston Consulting Group. He has more than 17 years of experience at the coalface of leadership and business. We also have with us Dr. Teresa Anderson, the CEO of Sydney Local Health District. Dr. Anderson has over 30 years of experience as a clinician and manager in the public health system. She's been the General Manager of Liverpool Hospital and Director of Clinical Operations at the Sydney Southwest Area Health Service. Craig Smith is with us too. He is a technology consulting partner with Deloitte, and in a previous incarnation there, he was partner for Deloitte's Health and Human Services practice in Australia. He spent 3 years at New South Wales Health, where he oversaw several transformation projects, amongst them the department's involvement in the whole of government data centre consolidation. We also welcome Dr. Michael Spence, the Vice-Chancellor and since 2008 the Principal Executive Officer of the University of Sydney. Dr. Spence is well known to us all, barely needs an introduction, but perhaps most importantly for our purposes here today, he is the Chair of the Health Professions Education Standing Group. Also with us, Gillian Skinner, the New South Wales Health Minister. Gillian's political and parliamentary involvement and commitment to health is actually quite legendary. It began in 2006 when she was made Shadow Minister for Cancer and Medical Research, and it's continued consistently since then. She spent more than 2 decades in public life, prior to which she was a journalist, actually, covering, amongst other things, the Vietnam War. I found that fascinating. And finally, and I'm not sure Professor Catherine Reshoggi actually needs an introduction, but just in case, Catherine is the Dean of Sydney University's Faculty of Health Sciences and a Professor of Physiotherapy with a PhD in neuroscience. She's a widely published researcher and a highly awarded academic. And just to add to the accolades, Catherine has recently been made Fellow of the Australian Academy of Health and Medical Science indeed.
This is not simply a talk fest, and it's certainly not just another talk fest. So I wanted to make a couple of points to show how we've used your opinions and advice and the results of the questions that we asked last year. We've been working since last year to shift our business ahead, and what we came up with as the major problems last year, or some of the problems, were that we need culture change, both you and us, that we need to do things differently, and that we need to do them together. And so we've worked quite a lot on that journey. We're actually sharing our business a lot more. Apart from the whole university being engaged with our major partners like out at Westmead and many other places, the faculty actually is sharing business. We are on your strategic committees, you are on our strategic committees. We're working with you to design new models of education, particularly clinical education, and also experimenting and trialling new models of care. We're also doing a lot of capacity building work. So we're running seminar programs in various hospitals, and we're inviting clinicians to come to our PhD education programs, and they actually do come. So we're doing quite a lot together since last year. There's sort of a list of things that we want and that we do. But the things that we started the journey on, all of us, are if cost was not a problem. We didn't have to worry about cost, but it's a huge driver. That health is the focus, that we're focused on integrated care. And there's some examples where it is really working, but when we say integrated care, it is the hospital and primary health care where the patient has a seamless journey through that whole system, but also when they're in a hospital, that journey makes sense physically and in terms of health care, and that is all integrated. That mostly we're keeping people out of hospital because that fragmented primary healthcare system is actually joined up and integrated. We would have e-health records that would be available all throughout the institution, but also out into the community and probably Australia-wide. So we have technology that supports it, that leads into e-health, that we are working in a multidisciplinary way, that patients lead their own care a lot more than is happening at the moment, that we have different kinds of health professionals that are excellent clinicians that see the whole system, not just the patient in front of them, but can see how it all joins up, and so they can actually solve problems, that they use efficient, effective treatments, and that patients can truly participate in their own care, in leading their own care. That we only use tests when it's going to change treatment, not just for curiosity. And we need health professionals that have courage, that are brave, that can lead change.
The vexing piece to this is, how do we work in collaboration between technology and clinician or end user, the stakeholders that are using it? How do we get that collaboration going to get the outcomes that we need to facilitate, so IT facilitates the delivery of healthcare. It's not going to deliver healthcare, it's how do we get the improvement in the tools.
It has to be driven by our clinicians and managers and technical people working together so that we get the best patient outcomes. At Concord, we've been working on the electronic medication management system for 8 years, and people go, why has it taken you so long? We're actually trialling the first IV module in the world. We helped develop it, and that'll be used by everybody.
So broadly speaking then, you're saying that the technology is there, the will is there, but is it the take-up that is problematic?
I think sometimes we've got to look back and say, where have we come from? Where are we now? Look at that sort of level of engagement. Innovation will come from that, collaboration will come from that, different clinical outcomes will come from the access to that information. But there'll always be the next thing. There'll always be this other industry that's gone ahead and done something else, and there'll be other things to try. I think we've got increasingly a group of clinicians and health professionals and people working in health who are no longer, and maybe they were, afraid of technology. They want to embrace it, and they're seeing it in other parts of their lives, but all these things, they take time.
So I assume though that there's a lot of this will come back down to university level, to training people to go out there who will embrace all of this. Is that a challenge?
It's our job to educate health professionals for the next generation of health professionals for the changing health landscape. So in a sense, we need to be leading it because we've got to be predicting by the time they graduate, we've got the 4 years of education that's handing them out at the end.
We have to produce people who can think critically, who can communicate effectively, both orally and in writing, who can work in teams, who can work across disciplines, and who can solve real-world problems. And we have to do that not just for a tiny elite of people who come with enormous amounts of social capital, but 40% of the population between 18 and 25 on reduced resources. But that's a challenge and it's a lot of fun, and that's why we are, over the course of next year, entirely rethinking our undergraduate curriculum across the university to ask ourselves the question, not particularly in the professional degrees, which are to some extent set by the professional associations, but very much in the generalist degrees. How do we create people who can continue learning as a life practice? And that's the challenge too, obviously, for the professional degrees. How do you not just equip somebody now and then give them an occasional top-up, but actually produce professionals who want to know more in 6 months' time than they know now. And our students are ready for that. So that's the job of the university of the 21st century.
One of the strengths that we have now is in fact the partnerships with the university and the health services. I think it is in one of the best places it's ever been. I mean, we have our clinical services in university facilities, we have university staff in our clinical facilities, and if we're going to create and grow health professionals for the future, it actually has to be done in partnership. It's not something the university does and then when they've finished with them then we look after them. It is actually, as Michael said, a lifelong strategy, but we will be in it together.
Business partnerships will be critical, and we have to think about that differently. So we are the group of 8 university that is most successful in industry partnerships in research, that does more industry-based research contract work than any other.
Partnerships for us, but with universities, with health providers, are incredibly important. We've done a lot of work locally, I think increasingly over the last 3 or 4 years in developing some of those partnerships.
What is the essential next step in achieving meaningful implementation of e-initiatives? Do you believe that reform in the healthcare sector is actually possible without significant industry input from the get-go, from the outset?
I think it's about how do you create environments where all stakeholders can get involved.
Right.
And I think we do need to think, how do we open the doors a little bit for the corporate sector to be more involved in a more trusting way, rather than we do often get tripped up with there's a commercial arrangement at the end which is spending taxpayers' money, and that's important to make sure that that's fair. So how do we balance those two?
What we've done is put a pool of money together centrally. It's $180 million now, which we've said to our local health districts, you put some of your growth funding up, you go and find partners, whether it's industry, other providers, NGOs, the Commonwealth, and come up with programs that actually truly integrate a care based on right care, right place, right time, so patient focused. And we're getting some incredible models running across the state.
Which areas of the health system would benefit most from effective public-private partnerships?
In my experience over many years now, the real success in change in the health system comes when the clinicians and the patients work together. And if I can give you an example, the doctors were all talking about smoking and its problems for years, until a member of the community in the form of Simon Chapman came along and changed everything. It was the two working together. Similarly, breast cancer had the same sort of effect. The doctors who tell me that as specialists in breast cancer, they were at the bottom of the pile, and some of them didn't even like to admit their specialty. And it wasn't until women made demands about their needs and the doctors got together with the women, we changed health.
What are the essential next steps for cultural change in the Australian health sector? You have a choice of A, B, C, D and E. What is the rightful role then of IT in this particular discussion? How does it fit in?
Yeah, look, I think this is critical, right? I mean,
absolutely.
Michael introduced the concept of multidisciplinary teams with critical thinking around problems. But that can't be done without the end user, the patient. And the success that I have personally seen, that goes back to some of these initiatives that the Minister was talking about, the outcomes of that initiative, they were driven out of ideas from industry and consumer patient. That you can't do it. You can't do it without that end user input. Anything else is just theory, and it's a bet.
consumers and consumer representatives involved in the discussions between health system, industry, universities, that's not only inputting what the end users want and hopefully leading to more effective outcomes, it's also another level of accountability that gets around some of these ethical dilemmas.
Which areas of the healthcare system are at the greatest risk of moral hazard when public-private partnerships are used?
We talk about multidisciplinary, but I'm not sure anyone actually knows what that means or how to do it. So part of it is having porous borders as health professionals. So I'm a physiotherapist, but how I do what I do needs to be consistent with what the psychologist is doing, and the psychologist needs to do things that are not completely contradicting what I'm doing. So there's lots of things that we need to solve together, what we mean by patient-centered care, patient-led care. We need to solve some of those.
The Charles Perkins Centre is, for example, a great experiment for us in this. So yes, people have disciplinary homes, but in the Charles Perkins Centre itself, they are in project teams. And they're not in project teams where we put philosophers and physiologists together. They're in project teams where we put people with disciplinary skills that are just a bit to the left or right of their own, but in networks that are bringing people together across the disciplines. The challenge now is to take that, for us, is to take that sort of thinking into our particularly, but not only, our generalist undergraduate degrees, so that that becomes a part of the intellectual toolkit of every undergraduate.
There's a couple of things that I've thought about listening to the other panellists here. There is the excitement now. The consumer's ready for technology. They want the technology. You know, the excitement's there from industry. The excitement's there from the consumer. The technology is changing to facilitate. We've got to take this opportunity, and if we don't, we will be disrupted as an industry, just like everyone else.
What is the necessary next step to improve the efficiency and effectiveness of healthcare?
Rather than asking the question, are we there yet, without being too naff, there is an issue about how we say to students, enjoy the journey. And that ultimately means giving them confidence in the core intellectual skills that we're giving them.